Hello and good day, my dear Level 4 learners. Welcome to Competency Appraisal 2, Case Analysis Number 3 Presentation, a review on the care of clients with inflammatory and immunologic disturbances. Through this presentation, we will be able to review on the importance of our immune system, especially in this time of pandemic. Also, necessary and relevant information regarding certain conditions will be tackled for us to gain adequate knowledge, appropriate skills, and the right attitude towards the correct management for the promotion of health. This presentation will also equip us on the fundamentals regarding inflammation and immunology in preparation for the upcoming nursing licensure examination or your board exam. Just relax, enjoy the discussion, and get ready to learn. This is Mr. Benedict Dwight Lipitan, your facilitator for this review. Focus points for this module. First, we will be differentiating what is infection and inflammation. Second, we'll be discussing on the different chemical mediators which affect the inflammation and infection process. Next, the types of inflammation, infection, and exudates. For the main bulk of this module, we will be focusing on the following conditions: rheumatic fever, trichinosis, herpes zoster and simplex. We also have psoriasis, malaria, bullous diseases or the blistering disorders, and lastly, we'll be having HIV and AIDS. For each of the conditions, we'll be discussing on the disease process, how to assess the different conditions, how to diagnose, and most importantly as nurses, on how to manage these conditions. Difference between infection and inflammation. You may hear the words infection and inflammation together, but they mean very different things. Infection refers to the invasion and multiplication of bacteria or viruses within the body, while the term inflammation is the body's protective response against the infection. To have a simple differentiation, just take note that when we say infection, the path is from an external to an internal one. An external agent coming from the outside of the body to injure tissues. On the other hand, inflammation's path is from an internal to an external one. The inflammation occurs as a reaction from the body in response to the external agent. Here are the 5 cardinal signs of inflammation. Number 1 is heat. Latin name is calor. Number 2, redness. Latin name is rubor. Number 3, swelling. Latin name tumor. Number 4, pain. Latin name is dolor. And number 5, loss of function. Latin name is functio laesa. Let us now proceed to the different chemical mediators. What are chemical mediators? These are chemicals or substances of variation from the circulatory system, from the inflammatory cells, and from the injured tissues which are actively contributing and adjusting to the inflammatory response. The most common mediator would be histamine. Histamine acts to promote vasodilation, thus promoting the increase in the vascular permeability in response to an acute inflammatory reaction. Another would be the kinins. Kinins are proteins that cause inflammation and affect blood pressure. They have the same action with the histamine, but these kinins function specifically to attract neutrophils to the affected area. To add, both histamine and the kinins promote vasodilation. When we say vasodilation, they manage to widen the blood vessels to allow more blood to flow. Here are other examples of chemical mediators with their specific functions. We have the bradykinin, particularly the main cause of pain in an inflammatory response. We also have serotonin, which has the same effect as histamine. It also promotes vasodilation. And last would be the prostaglandins. These mediators also increase the vascular permeability for the main reason of drawing leukocytes or the WBCs to the affected area. They are also described as vasoactive, meaning they can cause changes to the blood vessels. And lastly, prostaglandins are also known to be one of the causes of pain and fever during the inflammatory process. For the types of inflammation, we have two types. I have prepared a table for you to differentiate the two types in terms of their onset, duration, purpose, cause, and outcome. I'll give you time to read in this. To add for the table in the previous slide, the inflammatory process can be caused by either of these two classifications. Number one is of an endogenous cause. It includes immunopathological reactions, neurological disorders, and genetic disorders. Basically, when inflammation is due to an endogenous cause, it primarily results from an existing condition or disease. Number two is of an exogenous cause. It can either be due to a mechanical, physical, chemical, nutritive, or biological cause. This exogenous cause primarily involves all external factors and chemicals which affect the inflammatory process. In terms of the duration of time, we have three classifications. Number one is acute. This type is of relatively short duration, lasting for minutes, 2 hours, or days. Number two is for the subacute. It may last from 2 to 6 weeks. The number three is for chronic. It may continue for several months or up to years. In terms of the degree of tissue damage, we have two classifications. Number one is superficial. This degree may affect just the skin surface or just below its surface. And for number two, profound. This degree may now entail deeper tissues, and some books also use the term deep tissue degree. Types of exudate. We have 6 types. Number one, serous. This type of exudate results from the outpouring of fluid that has low cell and protein content. This is very evident during the early stages of inflammation. This is also commonly found in cellulitis, skin blisters, and pleural effusion. Serous exudates are clear, thin, and watery in appearance. Number two is fibrinous. This is characterized by presence of large fibrins resulting to adhesions and usually found in pericarditis and peritonitis. This type of exudate commonly develops when there's a presence of vascular leaks that are large, or this may be caused by a presence of procoagulant or adhesive stimulus within the cells. Number 3, membranous. This exudate is characterized by loose white or gray substance lining the mucous membrane. Membranous exudates are also commonly found in inflammation of the gut and of the trachebronchial tree. This type of exudate is also common in conditions relating to the respiratory system. Number 4 is purulent. This is characterized by pus formation and are commonly found in suppurative infections such as boils and abscess formation. When we say suppurative, it consists of plasma with both active and dead blood cells such as the neutrophils, fibrinogen, and other necrotic parenchymal cells. Number 5 is hemorrhagic or the serosanguinous exudate. These exudates result from the rupture or the necrosis of blood vessels. It is usually characterized with hematoma formation. This type of exudate is also described as bloody because of the large component of our red blood cells released from the ruptured blood vessels. And lastly, number 6 will be the mucinous exudates. These are characterized by the presence of mucus and epithelial cells and are usually found in allergic rhinitis and runny nose. Let us now focus our attention to the different conditions related to inflammation and immunology. First, we have rheumatic fever. This condition is considered an autoimmune inflammatory process which usually develops secondary to a sequence of streptococcal infection, specifically from a group A beta hemolytic streptococcus. Persons who have experienced an episode of rheumatic fever are predisposed and are at risk for its significant complication, which is rheumatic heart disease. Rheumatic heart disease are evidenced by a new heart murmur or an abnormal heart sound. We also have cardiomegaly or an enlarged heart, pericarditis or the inflammation of the pericardium due to the presence of fluid, and the gravest of them all would be heart failure. Rheumatic fever has extremely variable manifestations and remains a clinical syndrome for which no specific diagnostic test exists. Being a clinical syndrome, clients may manifest several signs and symptoms to support the diagnosis of this disease. One tool considered to be essential in diagnosing rheumatic fever is through the use of the Jones criteria. Jones criteria has a major and minor category. For the major symptoms, we have 5. Number 1, carditis. Number 2, polyarthritis. Number 3, subcutaneous nodules. Number 4, erythema marginatum. And number 5, chorea. Carditis. Carditis is the inflammation of the heart which primarily involves all of its layers, the pericardium, the heart muscle, and the endocardium. Second criterion, polyarthritis. It is a term used when at least 5 joints are affected with arthritis or joint inflammation. It usually takes up until 4 weeks. Third are the subcutaneous nodules. These are deep-seated lesions in the skin located in the deep dermis and subcutis, often with minimal changes appreciated on the surface of the skin. It is usually evident over bony prominences. Fourth criterion is erythema marginatum. This is a rare skin rash that spreads on the trunk and limbs. And the last criterion is chorea. Chorea is described as a rapid, purposeless, erratic, and jerky movement of the face and extremities. This usually resolves within 6 months. Take note, having 2 out of the 5 symptoms of the Jones criteria highly suggests the diagnosis of rheumatic fever. Here's a sample picture with the major and minor symptoms under the Jones criteria. The minor symptoms may also support the diagnosis of rheumatic fever in addition to the discussed major criteria. Please familiarize the symptoms. As what we have discussed earlier, there is no specific or definite diagnostic exam for rheumatic fever. However, we have several diagnostic exams or tests which may support and give us a higher probability of diagnosing this condition. We have the following. First, throat culture. This is part of the possible diagnostic exams since the throat is the area of concern for the GOBHS or the group A beta hemolytic streptococcus. Second, we also have the rapid antigen detection tests. This is also utilized in determining the presence of the group A beta hemolytic streptococcus. Third, ECG or the electrocardiogram. This helps us determine the functioning of the heart in relation to the possible complications of rheumatic fever. Number 4, we can also determine a higher chance of a client to be diagnosed with this condition through an elevated or increased erythrocyte sedimentation rate or the ESR as part of the Jones criteria minor category. And number 5, an elevated serum C-reactive protein since this type of protein is usually present during the active stage of rheumatic fever. As nurses, we should have a widened knowledge on how to manage clients with rheumatic fever. First, for the medical management, clients with rheumatic fever are usually given and are advised for an antibiotic regimen therapy. They can be given with penicillin, either through intramuscular or oral route. Erythromycin is given as an alternative to penicillin. We also have cephalosporin and azithromycin. Prophylactic antibiotics may also be given after the initial antibiotic treatment. Why do we give them antibiotics over other medications? This is basically to treat and manage the presence of the bacteria causing the rheumatic fever, which is the group A beta hemolytic streptococcus. Aside from antibiotics, anti-inflammatory medications such as salicylates and corticosteroids may be given to address the ongoing inflammation. And lastly, anxiolytics are given, such as diazepam, as a symptomatic management for chorea. For the nursing management, we are mainly focused on the promotion of health education to our clients. We'll be teaching our clients about the disease, how to treat and manage its symptoms. We can also share to our clients the different preventive steps needed to minimize recurrence and complications of rheumatic fever. And lastly, as part of our responsibilities, especially when our clients will be discharged from the hospital, we need to remind and instruct them to report any signs of complications, particularly with this condition, such as thromboembolism and heart failure. Moving on to the second condition, we have trichinosis or trichinelosis. This condition is primarily caused by eating raw or undercooked meat of animals infected with the larvae of the Trichinella spiralis, which is the causative agent for this condition. After an adequate inflammatory response develops in the intestine, the female adult larvae is eventually expelled in the feces. However, if the larvae or egg of the causative agent is found in other areas such as the myocardium and the brain, it may result to intense inflammation, which may lead to further cardiac and neurological complications. Sharing to the group the life cycle of the causative agent, the Trichinaria spiralis, with the pathology of the condition. Signs and symptoms of trichinosis or trichinelosis. We have abdominal discomfort, cramping, diarrhea, facial swelling around the eyes or the periorbital edema, fever, muscle pain, and muscle weakness. The signs, symptoms, severity, and duration of this condition may vary. Take note, if the infection is heavy, clients may experience difficulty coordinating movements and may have heart and breathing problems, and in severe cases, death can occur. Diagnostic exams for trichinosis. We have the following. Number 1, muscle biopsy. Second, complete blood count or the CBC. And third, the indirect immunofluorescence, latex agglutination, and the enzyme-linked immunosorbent assay or the ELISA. First is muscle biopsy. Muscle biopsy is done to supplement blood exams. This is done by removing a sample tissue or a small piece of muscle, and it is examined under a microscope to look for the trichinella larvae. Second is the complete blood count or the CBC. This examination is typically enough to establish the diagnosis of trichinosis through the increase of the creatine kinase and the lactate dehydrogenase, which results from damage or destroyed muscle cells, and also an increase in the eosinophils, which suggests the invasion of a larvae. Third will be the different assays. This is used to detect the presence of antibodies developed in response to the presence of the Trichinella spiralis. For the medical management, clients with trichinosis are given anti-parasitic medications such as mebendazole and albendazole. These medications are effective in eliminating the worms and larvae in the intestine. Painkillers may also be given as a form of symptomatic treatment. For the nursing management, we need to educate our clients, especially on how to promote proper food handling and preparation. We need to provide adequate rest for a better pace of recovery, and also we need to emphasize prevention of this condition through proper nutrition and dietary practices. Next condition is the herpes zoster. Herpes zoster is also known as shingles. This is caused by the reactivation of the VZV or the varicella zoster virus, the same virus that causes varicella or chickenpox. After experiencing chickenpox, the virus lies dormant inside the nerve cells, spinal cord, and the brain. The main reason of this reactivation is due to the declining cellular immune system functioning. The pathology of this condition is through the peripheral nervous system. Presence of red rash and fluid-filled blisters are the most evident symptoms for this condition. What to expect of clients with shingles as part of our assessment? Number 1, painful vesicular eruption along the sensory nerves is very evident. Vesicles are small, fluid-filled sacs appearing on the skin. Second would be itching. Third, tenderness over the affected area. Fourth, body malaise and gastrointestinal disturbances. And lastly, would be inflammation is unilateral or one-sided in nature. Take note that in shingles, the presence of the rashes and vesicles are only localized in one side, unlike in chickenpox. Here's a sample picture of the actual rashes and vesicles evident in a client with herpes zoster or shingles. For the medical management, herpes zoster is usually treated or managed with orally administered acyclovir. Other antiviral medications include famciclovir and valacyclovir. These antiviral medications are most effective when started within 72 hours after the onset of the rash. Analgesics and other anti-inflammatory medications such as corticosteroids may also be given as a symptomatic treatment. Additional information: a specific vaccine named as Zostavax may be given for prevention of shingles in adults above 60 years old who had chickenpox. For the nursing management, we need to educate our clients on the importance of medication compliance and follow-up checkups. Health education on how to do dressing on the rashes and vesicles is also very important. Stressing importance on proper hygiene practices may also be part of the health teaching. Teaching them relaxation techniques would be very helpful to address the itching. Introducing diversionary activities to our clients may also help them divert their attention to their rash and vesicles. And lastly, to promote loose clothing to our clients to prevent rupturing of the vesicles. Just an additional information for the group, we also have another condition termed as herpes simplex. This condition can be classified into two categories. We have the herpes simplex type 1 and type 2. Type 1 is also known as the mouth or oral herpes and is caused by the herpes simplex virus type 1. And on the other hand, type 2 is also known as the genital herpes and is caused by the herpes simplex virus type 2. For the diagnostic exams, viral cultures are done to detect the presence of virus on the older and crusted patches, and rapid assays over an acute vesicular lesion. Both examinations help determine the presence of the causative agent, the herpes simplex virus or the HSV. For the medical management, use of sunscreen are advised for these clients, and also a suppressive therapy will be imposed to them through giving antiviral medications such as acyclovir, valacyclovir, and famciclovir. Psoriasis. Psoriasis is a chronic, non-infectious, inflammatory disease that causes overproduction of keratin. This is usually considered a hereditary defect, more commonly manifested in ages 15 to 35 years old. In people with psoriasis, this production process may occur in just a few days. Because of this, skin cells don't have time to fall off. This rapid overproduction leads to the buildup of skin cells, particularly with keratin. Here are actual pictures of clients with psoriasis and also a comparison to a healthy skin. Assessment data for clients with psoriasis. Presence of lesions which are described as red, raised patches covered with silvery scales. The nails of these clients are pitting, discolored, crumbling beneath the free edges, and usually separated from the nail plate. Lesions may also be present on the palms and soles, termed as pustular psoriasis. Complications include arthritis or inflammation of the multiple joints. And another one would be a condition named as erythrodermic psoriasis, in which lesions may be present all over the body. For the medical management, psoriasis still has no known cure. Existing management focuses on the removal of lesions, scales with baths using oils and coal tar, use of emollient creams over the affected area, and also stressing out on the importance of regular skincare and stress management. For the pharmacologic therapy or management, topical agents and systemic agents are usually prescribed to these clients. Topical agents such as corticosteroids with adhesive dressings are given to prevent further development and growth of epidermal cells. This is to minimize the overproduction of the certain skin cells. The systemic agents are particularly given to stop and inhibit the overproduction of skin cells by destroying them through its cytotoxic features. Also, these systemic agents help in providing supplementary skin nutrition. Nursing management for psoriasis. We still need to promote health education on what this condition is all about, how to control and manage them, and also the needed topical medications. We also need to emphasize to our clients on the proper handling of the skin, particularly by not scratching the skin. Use of warm water and pat drying would also be helpful in maintaining the skin integrity. Use of emollients or creams with occlusive dressings and oil baths are advised. Psychological support may also be given, focusing primarily on the effects to the client's physical appearance. And lastly, for management of arthritis through rest, heat application, and giving of salicylates or anti-inflammatory medications.